Good evening, one and all. Today, our topic is suction during PCNL. Yesterday, we had discussion on the fans RIRS in matrix stone, but today we discuss about the various suction devices during PCNL. The speaker is a very senior surgeon from Surat, Dr. Kaushik Shah. I will introduce and hand over the program to Sir. Uh, so the topic is suction devices in PCNL by Dr. Kaushik V. Shah. Dr. Kaushik Shah was brought up in Nadiad and grew up seeing the rise of one of the most prestigious MPUH in his hometown. He secured fifth rank in the state of Gujarat 1960 and completed schooling. Though his intent was engineering, he chose medicine to study most complex structure. He did his MBBS MS from Baroda Medical College, MCH from JIPMER, and he joined Kidney Institute IKD, was as head of the Urology Unit 2. He attended several conferences, workshops, presented various papers. He's in private practice in Surat, South Gujarat 1992, developed field of urology in South Gujarat. His interest in general urology and endourology. His interest in urolithiasis and strong inquiring mind guidance inherited to his parents from his parents. His journey in innovation gave to Super Perk with the help of Shah sheath. This is invention. His invention. He patented his innovation and got approved in China, India, and USA. He demonstrated the live surgery at number of places and he taught the technique to hundreds of urologists. He wrote chapters on super pair construction PCNL. He owned onward journey led him to develop the digital endoscope, and his design of dual multi-channel super nephroscope is patented. He ventured into designing, manufacture, and marketing medical devices. He has floated a company called Shah Endoscopic Solution Private Limited to provide wide range of endoscopic solutions in different fields of surgery and medicine. He is deeply spiritual and strongly believe in teaching of Gita. Thank you very much, sir. Nice CV. And with this introduction, I hand over the program to Dr. Kaushik.
Shall I share the screen?
Yes, sir.
Good afternoon. Am I audible now?
Yes, sir. Yes, sir.
Okay. And my screen is seen?
Yes, sir.
Okay. So, Dr. Chandramohan, you are doing a wonderful job by educating an online university called Facebook Pure Urology. And a number of urologists have greatly benefited, and I think we have crossed 5 figure. And I keep blessing you and giving a good wishes that you continue this program of enlightening the urologist for the newer advances and newer techniques in PCNL. So, I'm today I'll be delivering this topic called suction device in PCNL. This is my second or third meeting with Pure Urology. I dedicate this talk today to a mother who is 97-year-old. Uh, what made me to bring this today? I changed the catheter today morning, and it was a new Eurobag. After a few minutes, she called me and said, "Hey, you, what is this?" And he started asking all the different features of different things on the Eurobag, and I had to explain every part of it. So I realized that she has so much inquiring mind at 97-year-old. uh, any
Great.
small child, if anything is given, he will try to find out what is what, doesn't bother whether it breaks down or not, and completely understand the toy. So I request all the urologists that similar curiosity should be there for all the medical devices which we use. Then only we will be able to do the best job for the instruments. So, what? I hello.
Yes, sir. Proceed, sir.
So, so what I will cover today is to emphasize the value of suction in PCNL for different stakeholders, to make you aware of the different suction devices in PCNL, to brief you about them, to use in different scenarios, and I want to resolve all the issues which may have stopped or may are stopping you from using suction devices in PCNL. I also want you to know how best to use sheath in different existing and evolving techniques of PCNL, and it can may be a default renal sheath system in all case scenario whether you want to use suction or not. And I'll be answering all the questions which may arise in your mind. So the basic aim of any PCNL surgery is to remove the stone, pus, debris, etc. with safety, completely, speedily, easily, economically, and it should be applicable in all case scenario. And suction devices is greatly useful to fulfill these aims. For the patient, there are number of benefits. Complete stone clearance, easy collection of stone samples for analysis and patient's relative satisfaction. For surgeon also, there are a number of advantages. For the OT staff also, there are advantages that there is practically no spillage in the OT theatre, easy stone collection, reduced need of exchange of instruments during the surgery, minimal malfunctions of the instruments, and the hospital is pleased if the patients and doctors are happy. So suction devices, let me talk about the suction. It's one of the easiest way to create a pressure gradient for transfer of materials from one place to another. In our case scenario, from pelvic system to the outside of the body. And that is what the endoscopic surgery is meant to be. So uh, whenever there is a new device in your hand, try to know why it was designed, know each part of it, how the design is helping to achieve the basic aim, what is its usefulness, how to get the best benefit from the intended use, how to get extra benefit, how to keep it functional during the use, how to detect malfunctions of the device, how to correct those malfunctions, how to reprocess it, how to make it ready for the use, and so on. Unless you know all this, the device will not give you the desired results. And you also should know where to use, what benefit it can give other than, and what are the limitations of that device. So, coming to the suction, the space available in the PCNL is for the suction is the nephroscopic working channel, the space by the side of the nephroscope in the renal sheath, and the space in the renal sheath when the nephroscope is not in the lumen, and a lumen of the ureteric catheter. So there are different pathways of using suction. One is lumen of the lithotripsy probe, and there are three different techniques called shock pulse lithotripsy, triology, and laser with suction. Lumen of the suction cannula itself, and the lumen of the sheath, where suction cannula inserted blindly in the sheath in absence of nephroscope, and Sasukopak sheath where the space is utilized, full space is utilized. Now, any suction device have different components. It has a hollow channel communicating the PC system. In uh, so either it can be blind or you can see through it. The suction machine, which is creating the suction power, suction control mechanism, and the different features of that device. It may be that the suction is not the primary aim. It may be a primary. It may be a secondary aim. So today I will cover different devices like shock pulse lithotripsy with probe, triology lithotripsy, laser with suction, Shah superpoxy, and the suction cannula which is most commonly used. This was one of the most important day in my life. Annual conference of American Urological Association. They transmitted a live our superpop technique from India from Mujibhai Patel Urological Hospitals. I, Dr. Sabnis, Dr. Madhu, and Dr. Janak has demonstrated our PCNL techniques, and immediately after that, the shock pulse lithotripsy was also demonstrated. So both shock pulse lithotripsy and the superpop was demonstrated on the same day to the highest forum in the world. So this was a great day, and it was in 2015. And we published a paper in 2017. It was a beautiful article. The study period was 2014 to 15, and the sheath wall size was like a flexible ureteroscope sheath, 10 to 12 range, and we have a number of sizes from 8 to 20 centimeters, and we published our results way back in 2017. Now coming to the shock pulse lithotripsy, it has a probe which is a hollow probe, and shock pulse are transmitted which breaks the hardest stone, and the ultrasonic lithotripsy pulverize the stone, and all the stone fragments are sucked through the suction probe. So both the techniques were demonstrated on that same day. It was a historic day for the suction in endourology. So Stockpol's main aim of that lithotripsy was polarize the stone into a very small fragments, and the additional aim was to suck the fragments that are created, and the continuous flow in the probe was needed to cool the probe, and it was using both way. So the combining powerful lithotripsy with suction was a great advancement in endourology. Now, this is a way the shock pulse are created and the ultrasonic litho probe is also created, and it is being continuously sucked. Similar innovation came from Swiss lithoclass and in form of triology. Yeah, the principle was same. It is using a ballistic energy instead of shock pulse lithotripsy, and you can change the settings of the ballistic energy, ultrasonic energy, and the suction. All three can be changed, and it is giving wonderful results. The only issue is that it is a one-time probe, and you have to reuse again. You cannot reuse. So this is a very heavy handle of a triology probe. So comparing the principle of shock pulse and triology is almost the same, but the cost of that machine is in terms of lakhs of rupees and needed a dedicated probe as per the track size. We need a bigger nephroscope, a costly probe, and the small suction channel, and portability, which is prevalent in India, is not possible. As compared to that, the Shah sheath, it costs in thousands of rupees. It's useful in all track sizes. Practically, there is no breakdown, no maintenance. There is a big suction channel, and you can take it anywhere. So let's talk about Shah sheath with suction. So this was designed to resolve the issues of PCNL in all forms of PCNL with suitable modification in the seat system which we are using. And suction is one of the most prominent feature of Shah sheath. So here the space for suction is the whole, this space is available, and this space is also available for suction. Now the component of sheath is that just we are interposing the saw sheath instead of employer sheath, and we are using the suction machine with a in between stone catheter bottle. So the component of saw sheath is dilator, sheath, metal cannula, suction chamber, connector for the endoscope, silicone suction tube, stone catheter bottle, silicone tubes again, and the suction machine. So here you can use any suitable dilator, but the dilator is coming with it. Then there is a sheet, there is a connector, and this is how it is working. This is the basic design. Now, in one form, the suction master is attached to the sheath, and this is a dedicated dilator, and this makes a complete system. In another version, the suction master is not attached to the sheath, and therefore, in a multi-track PCNL, when you are putting multiple cells with, the space is not occupied. Plus, this is also autoclavable, and we can use again and again. You can use Starad, plasma, or ETO. Everything is possible. So the complete scenario is that one is a non-autoclavable version where the suction mass is fixed to the sheet, and in another this is separate. And the best part is it is available in the full range from 12 to 24, and the different lengths. Default length is 14 centimeter, but one can have any size of length available. So that smaller size is good for children, and longer is good for obese patients or for supine PCNL. Not only that, the end, it can be round or it can be oblique also. So now coming to the most important part, a heart of the Shah is a suction master. So here is the suction master. There is a central reservoir, and it's connected to the four different things. One is a suction control opening. Second is connecting to the renal sheath. Third is an outflow, and fourth is attached to the connector. So at a we have an option of the outside system can be open or closed just by movement of a finger tip, and the connect uh, so the dilator has a tip which can accommodate a guide wire for 12, 15, and 18, and it can accommodate the guide rod for 21 and 24. So you can use any size, and the it is dedicated for each sheath. It is a part of the Shah sheath supply, and therefore in one step you can both dilate and insert the sheath in one sitting. Possibility of over dilatation and opposite wall pelvic perforation also can be limited. Now the sheath tube. Uh, in one version, it is suction chamber is inbuilt. In on other, it is detachable, and it is made of metal so that it can last long. That is the part that goes into the body. The terminal end can be round or angled as per the request from the customer, urologist. Different length and sizes of the tube is available, and it can be placed over a dedicated dilator or any conventional dilators. And one can use without or with connectors. So this is all what you have to do. Instead of using routine employer sheet, you just replace with the Shah sheet. You may attach suction, you may not attach, but it can work like any regular employer sheet. By addition, you can use number of advantages. So in the suction master, the most important part is the reservoir. This part is the reservoir, and it allows the fragments to fall in the chamber for outward journey. If you change the position, the fragments do not go back in prone position. This is the upper end, but the fragment will not go back because it falls into the chamber, and it is to receive the fluid. And if the outflow is not blocked, the fluid will go down and reservoir is completely empty. It is made transparent so that if you have aspirated a bigger fragment and it's not going downwards, you can see it, and by separating the connector, you can remove those fragments. That's the reason it is separate. Here in the suction chamber, the fluid is completely empty. That means it is working, and when it is fluid is coming out, that means there is obstruction to the flow of the passage, and that's how you can come to know whether suction is working or not. If the fluid is coming from the air vent, means suction is blocked. If it is not coming, chamber is empty. That means our system is working perfectly. Now coming to the suction control opening, this is the heart of it. This is to design to control the suction. If it is open to air, whatever the fluid is coming into the reservoir is sucked, but the pressure is minimal pressure is transmitted in the PC system. So it becomes an open system. When you close it, it becomes a closed system, and all the pressure is transmitted inside the PC system, and therefore we can just by a fingertip, you can activate the suction and close the suction. And the position is such that any assistant have a free access to that suction control opening. So you can see that the assistant is putting her finger and nothing is coming in a way. And if a surgeon wants to, you just hold the sheath and put an index finger, and the suction is under control. So this is the beauty of this part, and it is so comfortable to hold the sheath for the movement of the sheath. Now coming to the fluid outlet opening, the fluid outlet opening through which the fragments are coming, and therefore it is of a 8 millimeter size or 24 French. So any big fragment that comes into the chamber will always go out, it will not get blocked. And this suction chamber or the suction master is common for all sheath size, whether it is 12 French or 24 French. So this is a common part for every tube, and it is connected to a very wide bore tube so that fluid and fragments can go very easily. If you attach, the operation theater is not soaked and it is completely dry, and all the fragments are also easy to collect, and therefore it becomes very good for the OT staff. Now coming to the connector. This connector is allowing the system to make it air and watertight. So there are different ways. One is a silicone tube, and these are the silicone cap, which makes it an air and watertight system. When the endoscope is inside, no air or fluid can go through by the side of it, and it allows very easy in and out movement of the nephroscope, and you don't need to take out the nephroscope completely from the chamber. Just allow the fragments to fall in the chamber and you can go in again. So in and out movement is very easy. Now for the nephroscope not to hit the suction master, The lumen of the connector is designed in four different sizes, and it is labeled as S, small, medium size, large, and extra large, so that different sizes of nephroscope can go in easily. They are marked on the connector, and therefore you have to use the corresponding silicone cap and this and this link to the nephroscope for the easy functioning of the instrument. Now the suction tube which is attached to the fluid outlet is sufficiently rigid so that it does not collapse with the suction. Inner diameter is 8 millimeter. Most of the suction tube which we are using has no 8 millimeter diameter, is much smaller in the diameter. So this is 8 millimeter diameter so that there is no stone that is getting blocked in between, and all the stone gets collected into the stone collecting bottle, and it has to be used sterile. So please use the same suction tube which is supplied with the sheath. If you use other suction tube, the result may be suboptimal. So always keep this tube reserved with the sheath. Now the suction stone catcher bottle, the fragments which comes gets collected into the bottle, and only the fluid goes to the suction machine. So it is very easy to collect all the stone plus the stone fragments, and may have to travel a long distance to reach the suction bottle. So there will not be any strain stress or blockage in the suction tube, and also it is used sterile and it can be autoclaved. So you can see here that you don't have to collect the fragments by putting in a kidney tray. It automatically gets connected, and you can collect all the dust, small particles, and everything. And you can use a conventional silicone tube to connect from the suction stone catcher bottle to the suction machine. Now the suction machine has to have a mechanism to control the suction pressure. Excessive suction pressure is not advisable. Plus the suction machine should have a large suction bottle or a mechanism to empty the bottle without dismantling the system. So low pressure suction with a provision for emptying is important because large volumes of fluids are going to be used in PCNL. So when you want to use a suction, attach the suction tube to the Shah sheath. If you do not want to use a suction, you detach the suction tube. Keep the suction machine on throughout the procedure. When the suction is working, only air will be sucked from the reservoir. If you close the suction control opening, then only the pressure is transmitted inside. Some amount of suction is transmitted because it is sucking both from the suction control opening and inside. And set the suction machine power to whatever the units are there on the machine. It can be megapascal, then it is 0.02 to 0.25, or it can be 0.2 to 0.25 bar, or 150 to 200 millimeter of mercury. If there is no, then start with the lowest setting possible and increase only if it is necessary. Use of retrograde irrigation is important because when you are withdrawing, there has to be some fluid going from below, so it helps to prevent the renal mucosal injury by excessive suction. So now you have a sheet size, different diameters 12, 15, 18, 21, and 24. You select what track size you want, and depending on that, you use the select the sheet, and the connector which you want to use is decided by which nephroscope you are using. So the sheet size is decided, diameter is decided by the track size, and the connector is decided according to the nephroscope which you are using. If you are using a mini pop nephroscope, use M connector. If you are using a Dresden 18 French, you use an L. If you want a bigger, then you have to use XL. All is marked on the connector. So this is very important part one has to understand. Now, if you are want to use only mini-pop nephroscope, because the nephroscope is required now for irrigation and pneumatic or laser lithotripsy and the vision. So that is enough. So if you use a bigger sheet and a smaller nephroscope, there is a lot of space by the side of it for the fluid and fragments to come out, and you can do a good job with a slightly larger sheath with the same size of endoscope. So the preparation required is very minimal. All what you have to do is attach a suction tube, stone catheter bottle, and then machine going. This is all extra precautions you have to use. Whenever you want to use a suction, just attach the suction tube to the fluid outlet and control the suction. That is all. There is no extra requirement is needed at all. No extra gadgets, nothing. And the sheath is working as a visual suction cannula. So the Superbug system requires only three changes. One, if you want to use a simple, it's all right. Otherwise, you can use a multi-ureteric catheter. It has a number of advantages which I am not going to discuss today. Uh, Plus, whatever sheath size you want to use, instead of regular sheath, you use a Superbug sheath. And whenever you want to use a forceps, don't use the forceps, use a suction, and all the fragments, multiple fragments can come out simultaneously. So the procedure starts, use a simple sheath instead of M plus. Initial version was having a metal suction chamber. Then we have switched over to the transparent one and lighter weight because it was creating imbalance. The outside part was becoming heavy, and therefore we have switched to the autoclavable version with this. Now, the most important part is the trick and tricks. If you want to use safely Shah sheath, you try to see that you do advance this position only if you want to do an initial nephroscopy. But if you want to advance the sheath, do not advance in this way because there is a difference in the size of the nephroscope and it can produce trauma to the renal tissue or the infundibulum. So the best way is to withdraw the nephroscope inside. Now see the end of the sheath and under vision advance this part, and now you advance the nephroscope. This is very important even if when you are using a fence. Do not advance the fan sheath when the ureteroscope is beyond the end of the fan sheath. Otherwise, there will be a significant injury to ureteric mucosa and UPJ. So, it is important that even in fans, the same principle should be applied. Otherwise, the chance of ureteric stricture would be very high. This is the most important point I want to convey today to this audience. Why this is important? Because there would be a lot of movement of the sheath to reach the desired area of interest, and lot of time the fragments will come of its own towards the sheath and to be sucked. So always bring the sheath and near the stone fragments. Now bring the nephroscope near the stone, start doing lithotripsy and use a suction, right? This is a way to utilize fans or a Superbug Shah sheath. Now when you do a scopy, on initial scopy, if you encounter a turbid fluid, most of the time people say put a nephroscopy and come out. Don't do that. If you find a turbid fluid or pus, decrease the irrigation height to 30 centimeter, continuous low pressure irrigation and suction with a keep an eye on the renal pelvic volume. Do not allow it to increase and keep on sucking all the fluid materials which are inside the pelvic system. The way we are doing in an open abdominal cavity, we suck every contaminated area and give a good wash. Same thing can be possible here, and it should be used within no time. Almost all collected pus in PCS will be sucked from all parts if it is not blocked by the stone. So the aim is proper drainage of pelvic system. Now, depending on the different parameters on the infection and the status of renal mucosa, if it is fiery red, don't go ahead, just put a nephrostomy. But if you see that renal mucosa is normal looking, vital parameters are normal, you may go ahead and complete the stone removal under low pressure. Now coming to the pneumatic, how best to use pneumatic in any case. In pneumatic, don't try to corner the stone. Just put a pneumatic probe on the stone and activate the way you are using a laser fiber. Do not use suction or use minimal suction so that there is some fluid behind the stone. So when you are hitting the stone, If the energy is not utilized to break the stone, the energy would be absorbed by the fluid and it will not damage the renal pelvic mucosa beyond the renal stone. So leave some fluid to absorb the energy to prevent the renal pelvic injury. Make the fragment small enough so that it comes out of the sheath easily, and check the chamber whether the suction is working or not. So the principle of fragment removal is dusting a small fragment. It can be a bigger fragment. You don't have a control on the fragment size, so it can be in three different sizes: small fragments, bigger fragment but smaller than the sheath diameter, and the bigger fragment than the sheath diameter. Both above two fragments can be sucked. In first part of the fragment will come out continuously by the side of the nephroscope, and other fragments can be removed when you withdraw the nephroscope and activating the suction. Here you are seeing that my sheath is near the stone and the nephroscope is inside, and I am using a pneumatic. You can see on the other side it is just I am holding, I am not pushing, and I am just changing a different location to break the stone, and the stone fragments are in different sizes. I keep on doing it, and whenever the assistant feels that the vision is not proper, she will or he will put a finger to activate the suction. So keep an eye on the suction control opening on the other side, and you will come to know how beautifully the assistant can start and stop the suction. See, my assistant has come and she has put a finger to activate the suction, and the fluids are coming. So this is how the suction can be very intelligently done by an assistant, and you can continue doing the pneumatic lithotripsy. And when you feel that adequate fragments are done, one can stop and start removing the fragments. Same thing is true for the laser lithotripsy. The aim is not to dust the stone, aim is to fragment the stone. And all the fragments when can come by the side, and because of suction, there is a continuous clear fluid, there is no store effect, and all the fragments that are coming can come out by the side. If you find that it is not coming, then the assistant can create use a suction and taking out. Now enough fragments are there, so the laser fiber is withdrawn and the surgeon takes the control, and gradual withdrawal, you can see number of fragments are being sucked out with one go. In one step, lot of fragment, it's not one fragment the way it is in vacuum cleaner effect. Here the multiple fragments can be sucked out comfortably, easily, speedily. So now the fragments in the ureter, if it has gone, stop the inflow from the nephroscope, start the retrograde irrigation and start the suction, and all the fragments which were in the ureter. Here is the role of multi-hole ureteric catheter. You don't have to withdraw the ureteric catheter into the ureter for retrograde irrigation, and few movements will bring out all the fragments from the ureter, and ureter can be free of the fragments so that the exit procedure can become much easier. Now you understood how the Shah sheath is used, how the suction is used, how the pneumatic is used, how the laser is used. Now coming to the different easier ways of doing the Shah sheath. If you do this, it can be like a simple mini pop sheath or ampler sheath. Please do not keep the guide wire inside the ampler sheath. If you want a safety guide wire, it should be outside the sheath, but not in the lumen of the working sheath. So this way you can complete the job like any other simple ampler sheath with number of advantages. Now, if you attach a tube, the fluid which is coming out would go into the bucket wherever you have put the tube, other end of the tube, and there will not be any water play the way you are seeing in any other procedures like mini pop sheath or a regular ampler sheath. So the OT is very clean, free of the infected system in flowing on the body. Now, when you attach a connector, the in and out movement of the nephroscope, which is very common in mini pop with vacuum cleaner effect or other things, You just bring out the nephroscope up to the chamber and let the fragment fall into the reservoir, and you can go in again. So in and out movement of the nephroscope becomes very easy. And when you want a normal renal volume and pressure, do not use a heightened irrigation, and you can do this procedure very easily. And this technique is very useful in initial inspection or during the lithotripsy if required. So the renal pelvic volume pressure is required. Do not activate suction. Use, and that is required during initial inspection. And if required, you can always activate the suction. Now, this is a very important feature of sheath. Both openings are there. If you close both the opening, there is no place for the fluid to go, and it would stay inside. So that way you can increase the renal pelvic volume, and if you feel that there is enough, and now at that time if you reduce the irrigating height, the renal pressure will not rise, renal volume will increase. This is very useful in supine PCNL because the system gets collapsed and it is difficult to go in different parts of the system. So this technique is used in number of situations. Here you reduce the renal pressure, height of irrigation, close both hands. This is required at the end of a surgery to check all the calyces. So because it opens up the calyceal neck and you can enter into the calyceal neck to inspect. So this is very important feature at the end of a surgery. If there is some residual stone and which you are not able to locate in the PC system, you use this, and some calyceal neck which has closed will open up and you can enter into it and remove the stone fragment. So this is very important to locate the residual stone or some stone which you are not able to locate. And during supine PCNL, you can always prevent the collapsing of the system. And during supine PCNL, all the fluid will not come on your head or your body; it would go in the system. So this becomes very useful feature if you are doing supine PCNL. And when you are using a full system, there is no question, it is going to work the way it is designed. So if you want to have a reduced renal volume and pressure, it is very important in several situations. Use suction control opening judiciously. If you use suction control opening in a relatively close position, the system will collapse, pressure will go down, and it is important during the fragment removal when you are suspected infected system, when there is a real or suspected renal pelvic perforation, no extravasation would occur through the renal pelvic perforation. You can go there, pick up the stone fragment which is lying outside without fear of extravasation. During hydronephrotic system also this is very useful, and it can really augment the vacuum cleaner effect. There are a number of review articles on suction and PCNL, and it has said that mini PCNL with suction reported superior outcome or operative time and stone free rate to mini PCNL. This is all what we want. And not only that, it reduces the infectious complications by combination of intrarenal pressure reduction and faster respiration of irrigating fluid, reducing the risk of sepsis, enhance intraoperative vision, and improve lithotripsy efficiency, which makes it a very attractive evolution for PCNL. There are a number of trials that has been done with the thulium fiber laser with Minipur. Uh, it is used with the Moses technology. It is used with triology. Uh, so number of different permutation and combination is used with suction, and it has shown a superior results. And the take-home message on a review article is that suction-aided mini PCNL has superior outcome for stone-free rate and operative time than just mini PCNL. It also helps minimize infectious complications by reducing IRP and faster respiration of irrigation, and it can be used with any renal stone volume. The choice of correct lithotripsy depends on you, and it would give a better understanding in future. So, dear friends, it's a time for change. Now is the time to change from regular employee sheet to Shah sheet and use in whatever techniques you are using. Now the second part and very important is the suction cannula, which we are all used so far. It is a hollow tube, and at the end there is a trumpet valve. That trumpet valve can allow the suction to be used. This is for a pneumatic lithotripsy with suction, that is called lithovac. Here, press. uh, So the best situation to use this is a standard PCNL with pneumatic lithotripsy with regular implant sheath. This is very useful because we are living in India where there are a number of big stones, and we how to use a standard PCNL with 26, 28 French sheath also, and pneumatic. So this is a very useful thing. Mm. Insert a suction canal smaller than the working channel. Take a cannula and right up to the area of interest within the heap of the stone and fragments. Slight in and out movement, side to side movement will ensure all the fragments are sucked. If some stone gets stuck in the suction cannula, it cannot be used. So use a pneumatic probe to check the patency of the tube, and if the stone is stuck, you can use pneumatic probe to break it blindly and stone will be dislodged. Here lies the value of using this design. So in standard PCNL, after the pneumatic lithotripsy is done, stone is fragmented into different sizes. Those that are dust or smaller than the suction cannula can be sucked very easily, and all these are removed. So what remains is fragments which are smaller than the seed size. They are picked up with a forceps, and when there is a bigger than the stone size, we need to break with a pneumatic lithotripsy. So the cycle of pneumatic lithotripsy, followed by suction, followed by pickup with a forceps, and then again pneumatic lithotripsy goes on till the stone is removed. So what I've discussed is different suction devices to be used for all category of the stones. Very high-end patients, you can use shock pulse triology. For all other patients, you can use the Shah sheath. And if you want to use the sheath beyond 24 French, and you can use a standard PCNL and the suction cannula. So suction can be useful for all different types of scenario.
Thank you,
Any
sir.
questions? Thank you very much.
Thank you very much, sir. Can we close the screen, sir?
Uh,
A quick question, sir.
yeah.
Uh, Present days, what is the common size of the sheath you are selling nowadays? 16, 18, 20? What is the, I mean, you are not only a good urologist, but also innovative in making the Shah suction possible. Only two, three in India are working on innovation. Yesterday, we are discussing when the war has come, how many Indian instruments are making. Our Prime Minister also is very enthusiastic in Indian companies. You are the one among them. Congratulations for that. What is the size which
The
uh,
I'll answer that question. 18 French sheet is commonly used for those who are doing mini PCNR, and 24 those who are using like Dresden or slightly bigger nephroscope, 24. So the most frequently used sheet is 18 French and 24 French.
okay?
Those who are using laser, in a large number, good
What
laser,
is the normal
they
suction?
want 50.
What is the
Uh,
normal suction you recommend, sir? In the normal suction, nothing very important.
no, no, all suction machine has a suction control opening.
Yeah,
So we have to learn the suction machine, and they have a different knobs that increases or decreases the air inlet opening in the suction machine, and they reduce the suction power. So practically wherever I go, if there is a central suction, there is a mechanism. So you don't need to spend money for it. Just use and understand and see that the suction machine is in a working condition.
yeah.
And
You,
suction machine is the most important part. In the OT, two things are required. One is oxygen and second is the suction machine.
yes, yes.
These two are minimum requirement.
Yeah. Everybody will have these two. There is no doubt. Even the smallest theater will have these two. And
Yes.
you use routinely all cases suction Shah sheath only, sir. All
Yeah,
cases.
all
What is
cases.
the
Unless I want to use beyond 24 for a very big stone, then only other routinely it's only this.
okay? And infection rate is also very less with this.
Yes, it is very less. In fact, even in an infected system, you can easily suck out.
Yeah.
Therefore,
That is the
the
major advantage.
parameter, uh,
A
uh,
traditional teaching of stopping the procedure after the pus comes is not there now.
nah. In fact, it is better because whenever there is in the abdomen, there is a pus. What we do laparotomy, we suck out everything, we give a wash, and we put a drain. The same thing can be used here if the pressure in the system is low, and this is what is designed. So
Okay.
there is no need to stop. You go on aspirate. In fact, removal of the all pus material would improve the outcome.
Yeah. Okay, sir. Thank you very much for your nice talk. Highly appreciated. Very good,
Okay.
sir. Keep up with new flexible scopes and new digital monitors, everything you are inventing. And we wish you all the best, sir. Please.
So far we have come out with almost all rigid ureteroscope of 4.5, 6.5, flexible ureteroscope, cystoscope, nephroscope. So
Great.
practically full armamentum is ready.
Very good, sir. Great. And all the best, sir.
Okay. Any other question?
Nice, sir. Thank you, sir.